Good evening and thank you all for joining us today. On behalf of Jagsonpal Pharma, we welcome you all to this next Scientific Sangam 38 organized by ISOPARB Prayagraj in association with Allahabad Obs Gyn Society. We are all looking forward to esteemed faculty Professor Pratap Kumar masterclass on ovulation induction today. To restore ovulation and reproductive health in women, Jagsonpal presents to you Cystelia M formulated with the ideal 40:1 ratio of myoinositol and D-chiro-inositol. We also have Doxypal DRL or doxycycline 100 milligrams with lactobacillus to improve fertility. FE protein is our newly launched iron-rich brands to give the benefit of combination of lactoferrin with ferrous, bisglycinate, and all nutrients needed by a pregnant woman. A warm and hearty welcome to all the esteemed faculty and attendees. Please note this webinar is streaming live on Facebook and the link has been already shared in the chat box. To refer this webinar in future, please visit our YouTube channel, Jagsonpal Medical Insights. The organizing chairperson of Scientific Sangam series is Dr. Ranjana Khanna ma'am, founder and president, ISOPARB Prayagraj. She is president, vice president, FOGSI 2070, and currently ICOG Governing Council member since 2020. Welcome you, ma'am, and over to you to kindly initiate this session.
A very good evening to everyone. It's a delight for me that today we'll be actually hearing Dr. Pratap Kumar talk in details about one thing which is very, very, sometimes it is very frustrating at times when we want to induce ovulation, and it is as important for the IVF people as it is for the general practitioner, because all of us are inducing patients for ovulation. And before I start anything, first of all, we'll just pray, fold our hands and pray to Lord Shiva.
Trayambakam yajamahe sugandhim pushtivardhanam urvarukamiva bandhanan mrityurmukshiyamamritam. Trayambakam yajamahe sugandhim pushtivardhanam urvarukamiva bandhanan Trayambakam yajamahe sugandhim pushtivardhanam urvarukamiva bandhanan mrityurmukshiyamamritam.
So a very warm welcome to Dr. Pratap Kumar. I know he has a very, very, very busy schedule. He's a teacher of teachers, extremely busy and extremely much in demand for his teachings. So one thing I would just like to say before the chairpersons take over is that Dr. Pratap Kumar, we all know him as a wonderful teacher, but we also should know that he's very unassuming, very down to earth, and keeps on distributing these pearls of wisdom to all of us. So thank you so much, Dr. Pratap Kumar. I knew it took you time to accept my offer, but thank you so much for accepting it in the end. And we want to hear you in detail speaking about induction of ovulation, which is a topic very close to everyone's heart. So now I will hand over the session to Dr. Amita Tripathi, who is the founder secretary of ISOPARB Prayagraj, to please introduce the experts and start the session.
Good evening and a very warm welcome from my side also to all the faculty and delegates. My respectful regard to Pratap sir, Anuradha ma'am, Manju ma'am, and all the elders. This Scientific Sangam is so very special, different from the previous one, because this is a dedicated master class by the master himself, Dr. Pratap Kumar sir, on his favorite topic, that is ovulation induction. So I will not come between the subject and the speaker. And to cheer the session, we have two very celebrated and revered teachers from our part of India. Both have been professor and head of department of one of the finest medical schools of India. Both have been president of Uttar Pradesh Obstetrics and Gynaecological Society, authority of the subject with deep knowledge and the teachers in every sense. So to formally introduce Professor Dr. Manju Verma ma'am, she has been guru to me and a special teacher for me. She is recipient of various awards like Shivrava Narayan Gold Medal, B.C. Pant Gold Medal, Lakshmi Ratan Pandey Silver Medal. She has written more than 100 scientific papers, various orations, guest lectures at national, international, and state level conferences. Welcome, ma'am. Now I want to introduce Professor Dr. Anuradha Khanna, ma'am. She has been ex-head of Department of Obstetrics and Gynecological, Banaras Hindu University, Banarasi, ex-president VOGS, president SMF UP chapter, president Varanasi Menopausal Society, organizing secretary and chairperson of various very celebrated conferences. She has recipient of various awards like TJ Mukherjee IMA Award, WHO Fellowship, UICC Fellowship Awardee. Welcome, ma'am. And I will request Dr. Anuradha Khanna, ma'am, kindly introduce our speaker for today, Dr. Pratap Kumar, sir.
Good evening, Anuradha ji. I would wanted to welcome both Dr. Manju Verma ma'am and Dr. Anuradha Khanna ma'am for accepting my invite. Thank you so much for the invitation. And I would love it when Dr. Anuradha Khanna will speak about Dr. Pratap Kumar. But one thing I wanted to say, I don't know how many know, but he's got a great fondness for music and lives lives to the fullest. So, Anuradha Khanna ma'am, over to you. Please introduce Dr. Pratap Kumar so that he can begin his talk.
Hello, ma'am.
Thank you so much. Thank you.
What?
And it's my privilege to introduce Dr. Pratap Kumar. He is a very good friend of us, I will say. Always, when we see, we meet, we all enlightened just by seeing each other. And he is the very known, recognized personality, not only in India, but abroad also. He is National Vice President of Federation of Obs and Gynecology in years so back, that is in 1999. He is Inspector of Examiner, Advisor of Nation Board Examination, Examiner of undergraduates, postgraduates in several universities, appointed as an editorial committee of several journals, President, and then Karnataka State Obs and Gynecology Society 2011 to 12 under FOGSI, member of Task Force of Human Development, Disease Biology, Department of Biotechnology in New Delhi, member of Project Reverse Group PRG on the Reproductive Child Health, Indian Council of Medicine Research, New Delhi. He is also having 30 Vision 2018 leading lights in the field of reproductive medicine, year 2018 by IFS, Dr. Duru Shah Life Achievement Award 2017 by ISAR, FOGSI, Dr. Kuti Lifetime Achievement Award. This I remember that in 2009 also, sir, you have received an award from UP chapter in Varanasi. And this is 2011, Dr. D.K. Tank, Reproductive Healthcare. He has more than 300 publications and presented more than 1,000 presentations in national, international, everyone wants that in their conference, Dr. Pratap Kumar must be there. Editor of 10 textbooks and contributed to several chapters. So here I welcome you, sir, with the great knowledge we are going to get it from you.
Thank you so much, ma'am. Anuradha Khanna, it's a pleasure to see you and be a part of your program. And Ranjana Khanna, I could not say no to her, a great friend of mine. And of course, Amita Tripathi for conducting the whole program. And Manju Verma, I'm sure we'll see her. I will share my slides on this. And greetings from Manipal, Karnataka state. The topic for today is tips and tricks of ovulation induction. Once again, we are from the southwest of India, Manipal Academy of Higher Education. That is our university building with 4 floors of library for students and 4 floors of administrative wing. Now, when you look at the non-ART cycle, I would take you through the basics initially because I'm sure the audience are general OB-GYN people as well. So the non-ART cycle is the most common kind of ovulation induction. And how do we should know a little basic about what medicines we are using and how much to use and all that. Now, everybody knows this physiology of the follicular growth. When the graphene follicle is induced very well by natural or by medication, it will produce estradiol, which acts on the endometrium for proliferation. Once there is LH surge, there will be ovulation which has occurred and there will be corpus luteum. Once it regresses, she'll get the menstruation. But what one should know is the estrogen effect on the endometrium is important to know, which I'm going to show you a little later. And the corpus luteum also produces, along with progesterone, a little bit of estrogen as well. Now, this is an important slide because to get one dominant follicle, a lot of them are recruited from the reserve eggs. And the recruitment occurs, then you find the dominant follicle. But most important to get a dominant follicle is they need FSH and LH. I always say FSH, LH are friends, but the LH is a lower friend, a smaller friend. That smaller friend should never become a bigger friend. So if the LH goes up for some reason like polycystic ovaries, that will spoil the friendship. So the LH is always a little smaller friend than the FSH, though that we know when somebody has a high LH, probably you should set it right before we really do induction of ovulation. Only then there'll be a good estradiol formation and ovulation occurs. Now, whenever we start anything, we would start with estimating anti-Mullerian hormone, not always. If you find a good antral follicular count in the ultrasound, you don't need this. But AMH, the normal value is between 1.5 to 3.5 nanogram per ml. That's the last line there. It's a peptide growth factor, reliable for ovarian reserve marker. Anti-Mullerian hormone expression continues to increase until the primordial follicles are developed into small antral follicles of approximately 4 millimeters. What does this tell us? All these little primordial follicles will have AMH. Now, if the AMH is low, then most of these follicles become rapidly growing and they are exhausted. So the AM is like a gatekeeper. It will stop all follicles to grow unnecessarily. So if somebody has a low AMH, less than 1.5, they are exhausted because all the ovaries are, there is no gatekeeper action there. And all the little follicles will grow and they just are wasted. So when somebody has a normal AMH, we expect the reserve X to be good. And look at this, I always say the women are born with basket of eggs. They cannot produce number. They may produce more quality later. However, you do the ultrasound and you'll realize that this antral follicular count, the second one on the right side, is about 6. All the black spaces are counted. And then it's on, on the left side, there are only 4. The bottom one is 11. What does it mean? You count this antral follicle, the good number is 8 to 10 in each ovary. I like that number 10 because in obstetrics and gynecology, there are a lot of 10s, 10 hours of labor, 10 hours of cervix is dilated 10 centimeters, then lower segment is 10 centimeters, fallopian tube is 10 centimeters. The number, all the incidence is approximately 10%, and FSH must be less than 10, LH must be less than 10. All this 10 number is good. If you find that 8 to 10 antral folliculars there, the AMH will be usually between 1.5 and 3.5. Why should you know that point? If it is 8 to 10, then they need a normal kind of ovulation simulation. If there is a low AMH, then they need a higher dose. And if there's too much of antral follicular count and AMH is beyond 5.5, they're all this PCO kind, they need a lower dose. So I think depending on the antral follicular count and the AMH, you will realize that this dosage is important to understand. Now, in a non-ART cycle, in whom are we going to induce ovulation when the tubes are patent, intact uterus, responsive endometrium, and the cervix that allows ascent into if you are doing IUI, etc. That means in an ovulatory woman, also we can induce ovulation. In an anovulatory woman, definitely will induce ovulation, but you're doing some procedures like IUI, you have to induce ovulation, otherwise the result goes down in number. So the ovulatory dysfunction is important. Now, I don't test the tube for all anovulatory women. I just do induction of ovulation for about 3-4 cycles. If they don't conceive, then you do the tubal patency test. But in a regularly menstruating woman, I think you should test for the tubes at the initial outset itself rather than wait for 3 or 4 months. However, the aim is to maximize pregnancy rates and, of course, stimulate well, and keeping in mind the multiple pregnancies should be minimum. Now, in an ovulating woman, as I mentioned, you can take up women with unexplained infertility, mild endometriosis, and mild male factor. When it is mild, it only means around 10 to 15 million per ml. Normal is 15 million per ml. Less than 10, they are not meant for IUI. They are meant for other techniques like IVF. So please remember, when somebody refers a case to IVF center, or if they want to do some IUI, the minimum should be 10 million per ml. Only then you can stimulate them and do the procedures. Looking at the results, natural cycle IUI, though they are menstruating correctly, ovulating correctly, look at the result, 3.8%. When you use clomiphene citrate, it is 5%. Clomiphene and IUI is about 8%. So remember, it's only less than 10 once again. It's never more than 10%. But when you add gonadotropin, it goes beyond 10%. That means around 17%. So now you know another 10. All these results are approximately less than 10%, except when you use gonadotropin stimulation. Now, how do we use gonadotropin? I will tell you a little later, because you don't have to give gonadotropin throughout the cycle. You can give a little bit of sequential therapy, which I'm going to talk about. But one thing is for sure, clomiphene citrate is being used for ages, but people have not understood this. Clomiphene citrate has two parts. N-clomiphene, which is most potent, responsible for ovulation induction, and the zoo-clomiphene is cleared more slowly from the ovary. That means that accumulates in the body. And if you go on giving for 6 months and 10 months, it will accumulate so much, there will be ill effect on the oocyte. So, though it is well absorbed, etc. It is that I always say, sometimes you give for 4 months, you stop everything. She may conceive on her own. If you give for 6 months and 12 months, the zoo-clomiphene gets accumulated in the body, and then they cause a poor oocyte. However, certain companies have come forward now by removing the zoo-clomiphene. They're selling only N-clomiphene. So structural similarity to estrogen binds to receptor all over the body, and of course, it causes ovulation. Now, clomiphene citrate basically increases estrogen, the dominant follicle, and trigger mid-cycle LH surge as well on our own, and ovulation can be seen. That means N-clomiphene only can also be seen, but the half-life goes down, and it's also good for, of course, ovarian stimulation. There is no anti-estrogenic effect in the mid-cycle as well as in the luteal phase. How do we use this clomiphene citrate? Everybody knows it's either 50 milligram or 100 milligram. I start with 50 milligram in a thin-built woman, 100 milligram otherwise. But always start before 5 days, because the selection is important to know. Once there is selection, the dominant follicle becomes better. There is no need to call her on day 7 and day 8. You call her on day 12 or day 14. You expect a good size of follicle of at least 17 millimeter. I would wait for about 20 millimeter in a clomiphene cycle, because I want it a little bigger and a mature oocyte. However, if there's no response, you can increase to 150 milligram per day, up to 150 milligram. You can even extend it by up to 10 days of stimulation, and not more than 6 cycles. Now, the trigger, do we have to give HCG as a trigger? Because some people routinely give, but I don't give. I don't give routine HCG because sometimes it causes hyperstimulation and causes a big cystic kind of cyst enlargement. So when you have an LH monitoring, LH kit also can be used for LH monitoring. And if you find LH also two lines can observe the 2 lines and say they are going to surge, or you can sometimes just wait and watch. Most of them anyway rupture. Now, ovulation trigger, my good friends from Vellore, Kamath and George have published this. No conclusive evidence to recommend or refute the use of urinary HCG as ovulation trigger in treatment with clomiphene citrate means it doesn't need to be given always. However, if you are planning for an IUI procedure, I think it's good to give when the follicle is at least 18 to 20 millimeters. Then 36 hours later, you do the IUI. That means if you give on a Monday evening HCG, Wednesday you can do IUI, and we do only once. So there is insufficient evidence to determine whether there is any difference in safety and effectiveness between different methods of synchronization of ovulation and insemination. Of course, more research is needed as always. Timing of IUI after LH surge detection is as good as IUI after ovulation trigger. So you can do simple LH kit itself. 2 lines means you're going to surge now, and day after tomorrow you can do the IUI. So when you find there is no response by clomiphene citrate, you have gone up to 150 milligram and still there is no response. In a case of PCO, you have to add on metformin. And of course, recently also you got this myo-inositol, as the company person told in the beginning. You have inositol which can be tried, though inositols have not been told to be in the protocol, but they have written as it's a definitely you can try inositol. You can give metformin inositol combination as well, or even inositol as such. I would add on gonadotropin. What I would do is I would give 50 or 100 milligram of clomiphene from day 2 to day 6. Add a little bit, just 3 days. Just 3 days of HMG. Day 7, day 8, day 9 of 75 international units per day. That itself makes a lot of difference. There is no need to give gonadotropin right from beginning for 10 days. It's so expensive. I give this sequential regime for 5 days of tablets and 3 days of gonadotropin, and sometimes even twice. Day 7 and day 9 of 75 would be probably enough for most of these patients. And we also have letrozole when there is resistance. Clomiphene, tamoxifen I'm not using, so I'm not going to talk about it. But the word clomiphene failure means even after ovulation occurring, there is no pregnancy. It's called as clomiphene failure. But interestingly, 80% ovulate, 40% conceive within 6 cycles, and 10% conceive per cycle. Once again, that number 10 is a rough guess and gas number. I always say for postgraduates, if they don't know much, just tell 10%. Things will be okay. And no increase in ectopic pregnancy rates. Now, interestingly, the drug is not side effect free. They have hot flashes like a menopausal symptom. I had a patient who could not see properly. She had blurred vision. She went to ophthalmology department and they were wondering, she didn't tell that she has come to me for medication. But in our hospital, on the lab, on the computer, we see all wherever they've gone, we can find out. So I asked her, why did you go to ophthalmology? She said, I cannot see properly. I said, oh, come on. They won't know the side effects. I know the side effects. It's because of the clomiphene. You please stop it, you'll be fine. I just stopped clomiphene. The next few days later, she was fine. So she did not get any more medications. I think all of us should know some subtle changes. They don't come to us. They'll go to an ophthalmologist. And very rarely, of course, optic atrophy. Hopefully, we don't see such cases. But any side effect of the eye problem, please stop it. Breast tenderness plus pelvic discomfort, and of course, nausea like anybody else. But one thing what we find is undesirable effect on the endometrium. Sometimes endometrium thins out, and that is not a good point. If you find the thinning of the endometrium or around day 14, and it's not a good point, you stop the clomiphene citrate. So multiple births are high, no increased evidence of congenital anomalies, a little increased risk of spontaneous abortion compared to spontaneous pregnancies, but statistically not significant. Mild OHSS. I had a patient, they gave clomiphene citrate 150 milligram for about 5 days, and she just blew up. The referral came to me with 4 cardiac pulsation. That means one patient having quadruplets, 4 pulsatile babies there at 7 weeks. And I have done embryo reduction too, and then delivered twins later on. So I don't think we should get congenital, not congenital, but multiple pregnancies at all. So you should be very, very careful. If you get too many follicles, don't give HCG. You can give leuprolide. You give leuprolide, just 1 milligram of leuprolide instead of HCG. They ovulate and there is don't multiple pregnancies. But I sometimes abandon the cycle. I don't give them anything. But I think most of my patients don't have so many follicles because we are at a stage we know multiple pregnancy is not good and we don't have more than 1 or 2 follicles. The next popular is Letrozole. Those off-label, we are using it now. And we'll find that many brands are available, but the dose is 2.5 milligram once a day or twice a day. But in our PCO patients, even once a day is enough. Only if the BMI is high, you may have to give twice a day, because I have found when you give BD dose, they produce too many follicles. Though they say it's a monofollicular development, I'm finding it multifollicular also. But interestingly, there is not much of side effect on the endometrium. Endometrium is quite good, cervical mucus is quite good, and very less chance of multiple pregnancy. And of course, theoretical risk of birth defects have been disproved. Ovulation and pregnancy rates are comparable with clomiphene citrate. The same action, aromatase inhibitor, means androgens get converted to estrogen. So when you give letrozole, the aromatase there gets stopped. It kind of gets inhibited. It's aromatase goes down, and you'll find estrogen aromatase, the excess estrogen there. That means you'll find loss of negative feedback mechanism, increased FSH because of the aromatase inhibitor there, and then it will cause, in other words, it will cause androgen to estrogen more of that happens, more of estrogen occurs, and then there will be increased FSH and ovulation. Now, gonadotropin should be understood a little bit more, because the long back and even now, when you use the word HMG, human menopausal gonadotropin, it comes from menopausal urine. Long back, it has started in Europe. All the menopausal nuns from the nunnery were passing urine into a bottle, and it was go to the laboratory. They were extracting the HMG, but that contained LH too much and impurities also. So that is why HMG has LH and impurities. In further on, they removed LH, but impurities also were removed. It was called as purified FSH, and finally recombinant FSH, where no urine is taken. But as you know, more expensive things means more larger the technology means more expensive. So in my practice, I still use HMG a lot for IUIs, and even IVF I'm using that, because all of us know it has given very good response as such, but the best would be recombinant technology. But you have to monitor. You have to monitor when you give gonadotropin, follicular imaging, and occasionally estradiol monitoring, but not for routine, only in IVF cases. But when you give gonadotropin, you have to give HCG. You can't leave her alone, HCG or leuprolide. But if you give leuprolide 1 milligram, they have a corpus luteal deficiency. They're terribly depressed, the corpus luteum, and the progesterone goes down. But when you give HCG, there is no effect on corpus luteum. Now, HCG also has recombinant and non-recombinant. However, no evidence of a difference in clinical outcome between urinary and recombinant gonadotropin used for induction of final maturation. Additional factors should be considered when choosing the type, safety, cost, and drug availability. If you look at that, there's a good antral follicle on the left side, lots of them, more than 10. And but look at the second one, there's a good dominant follicle. That's what we need to know. A good dominant follicle means around 18 to plus, and then around 22 millimeters as well. Now, this is an important slide of endometrium. You will find that there are triple line. Triple line is a good estrogenized endometrium. You measure 1 centimeter below the fundus from outer to outer part of the endometrium, 1 centimeter below the fundus, because that's an embryo implantation area. Once again should be 8 to 10 millimeters, another 10. So 8 to 10 millimeter is a good indicator of a good estrogenized endometrium. However, we should never get this kind of ovary, too many follicles stimulated, and abandon the cycle as well. So in an ART cycle, basically, what we should know is a normal responder is one in whom we expect a normal response to ovarian stimulation, usually less than 35 years of age, regularly menstruating woman, and normal basal FSH and normal AMH. Now, in an IVF stimulated cycle, it is not basically to increase too many oocytes. Maximum embryo is, I think, ideal. Maximum conception rate also is ideal, but basically what we think is the live birth rate. The live birth rate and take-home babies are very important to know, and we should get the right kind of stimulation in an IVF. So the ovulation is not only for non-ART, but also for ART cycle. Since the audience listening are not too many of these IVF specialists, I would like to just simplify by saying there has been a paradigm shift from aiming of maximum number of oocytes possible to adequate number of mature, good quality oocyte. Asesh Kamal Sunkara, we always quote her from UK. She said so many cycles she's analyzed. But look at this. If you look at that, the number of oocytes, the best are approximately 15. So 10, again 10. 10 to 15 is a good number. Anything less than 10 is a low number. So there is no point in getting too many oocytes. The poor response will be seen when there's less than 9 oocytes. Most of our patients are producing only 9. They don't even produce 15, but they're still okay. But remember, 10 to 15 is ideal. More than 15 is too many. Less than 9 is too little. So our next step is to individualize the dosing based on ovarian response prediction.
Dr.
So,
Pratap,
yeah,
Dr. Hrishikesh had joined.
yeah. I'll
So,
just stop now and you can. We'll
then we
continue
can
later.
continue right from here.
Yes, yes.
Yeah, Dr. Hrishikesh. Hi, Dr. Pai, how are you?
Sorry. Hi, I was listening to Dr. Pratap Kumar. Wonderful lecture today. I don't know whether you know, but I always say that Dr. Pratap is one of the leading professors in our country and very, very highly intelligent human being and very nice person. One of the best professors we have got.
Yes.
I always told him also that he can, anytime if he stands for an election, he'll become president of FOGSI. There's no doubt about it. And Dr. Anuradha Khanna
Dr.
madam
Pai,
is
what
there.
is his
Dr.
answer to that? I also said the same thing to Dr. Pratap Kumar. So he says that he doesn't want to create any enemies, hence he will never stand for the election of president.
He has no enemies. So I would like to say that thank you for calling me, and I would like to pay my
So
respect
first,
to.
let me introduce you,
Okay.
Dr. Pai.
Okay. Yeah.
So first of all, I want to welcome our chief guest for the day, Dr. Hrishikesh Pai, who is our dynamic FOGSI immediate past president. We all know that last year, all the FOGSians were working for him. He kept us on his toes all the time. And I think, Rishi, that you are the only president who has been appreciated and loved by all of us. So, welcome, Rishikesh. And now to talk about him in detail, he is a trustee FIGO Asia Oceania, immediate past president of FOGSI, professor of reproductive medicine at DY Patil Medical College, founder and medical director of Bloom IVF, and they are opening more and more branches, if I'm right. Right, Dr. Pai? Yes.
Yeah.
And Chief Administrator FOGSI Manyata Project. And he's got a group society license with FIGO Women's Cancer Committee, editor, Indian edition of British Journal of OBGYN, editorial board member, Global Reproductive Health board member. And he's got a lots of awards to his credit, 59 awards, including honorary FRCOG from RCOG and National IMA 2022, and then Moggs B.N. Purandre Award, Kanak Goyal Community Service Award, and lots of awards, delivered 700 plus lectures, 20 plus orations, still delivering orations, many research papers, 200 plus citations, editor of 17 plus books. I could go on and on. Dr. Pai, you've done a lot of work and lots of positions he has been occupying. Past Secretary General, and we know he has climbed up the ladder in the FOGSI hierarchy. And past President ISAR, IAGE, Mumbai OBGYN Society, Maharashtra chapter of ISAR. And of course, now he's going to stand for FIGO president. And we all are praying that he soon becomes the FIGO president and makes our country proud. So, Dr. Hrishikesh, I wanted that to welcome you, say a few words to bless us and bless this master class from the master himself, Dr. Pratap Kumar.
Thank you, madam, for that generous introduction. And I would like to pay my respect to Dr. Anuradha Khanna, our doyen of UP. I remember one of fantastic, the UA when I was president. And of course, Dr. Ranjana Khanna is another doyen of UP. And I hope, madam, you go further, one day become ICOG chair. Dr. Chitra Pandey, Dr. Amita Tripathi, also again another very leading person. Thank you, madam, for calling me. Dr. Amit Saxena, And Dr. Parul, of course, the young Parul is there. Also, one of the leading now consultants, Deepa and Deepika. So I would not like to waste much of your time. But as I told you, Dr. Pratap Kumar and me go a long way. We met first in the AISQ only. I don't know whether you remember in the Nagpur All India Conference,
Yes.
way back. Yeah, and then of course we have had a fantastic association, and both of us have been bound by a lot of relationship, including IVF also. And one of the best units in the country he leads in the Manipal Hospital, and a lot of people he has taught as professor. And all of us, we always look up to the professors because they sacrifice a lot for others. So that, for us and even for the general society also, if in a medical legal case, if a professor gives a particular opinion, this whatever opinions you get from private judges will always listen to the professor's opinion. So that kind of respect we have in our country for the professors. So it's very great. He represents that respect. And of course, coming to the topic, induction is of course a very important, like a basic important pillar on which the whole infertility practice rests. Induction, and very important to learn all the important aspects of it. And I'm sure that, sir, because I was listening to his lecture, I was there already. So I also learned a lot of new things. So every time you listen to a lecture, you learn a lot of new things, and it enriches you. So every lecture is important. It's something or the other new thing you learn when you listen. So thank you very much, madam, and all of you for calling me. And we are looking for the ESG. I was actually busy putting the permutations and combinations, but it's a
Yeah,
colossal task.
we still haven't got Dr.
Yeah. So
Pratap. You've
tomorrow,
got
day
the
after,
invite
No.
topic.
day after tomorrow, the invitations will start going out. We are
Okay.
start doing the fine tuning and all. So tomorrow, day
Yeah.
after, we'll start invite. Dr. Pratap has been given the Allagolics lecture anyway.
Oh, thank you.
The new one, the new product on the block. He will
Elagolics.
probably
Yeah,
be one of
yeah,
the first to give that.
yeah.
Okay, thank you.
So anyway, so thank you very much, and looking forward to all of you coming to January. Dr. Ranjana, just send me a few of the important names again, and Dr. Anuradha, madam, also few names, important ones on the WhatsApp. Thank you very much.
Okay. Okay.
Bye.
Bye.
Bye, Rishi. Thank you for the good
Bye
words.
bye.
Pleasure seeing you again. I'll just continue
you.
my talk. We'll have to log in at 5:30 for Pratik Tambe's ICOG webinar.
Oh.
My God. Okay, bye.
Okay.
Bye.
Bye-bye.
Bye, 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 Chitra. Bye.
Dr. Pratap, while you're putting it on, I just wanted to ask you one thing.
Huh.
That can we give 5 milligrams of letrozole from day 2 to day 6?
Yes, you can give. If there is no response to 2.5 milligram, I give 5 milligram.
And what
In
about
fact,
the much touted extended regime?
yes, I am giving that. I am
For
giving
10 days. For 10 days
10
you are
days.
giving.
10 days, it works very well.
It works
And
well.
that also in a poor responder, you can give 2.5
Okay.
or 5 milligram per day for 10 days. And you'll be
Okay.
surprised to find there's a lot of difference in a poor responder in those kind of PCO specifically.
I've never actually tried giving for 10 days. So I was wondering
In
if
fact,
it's
one of my patients was not responding to that. Also, I made it 2.5 milligram 3 times a day for 10 days. And she got a
okay.
very good follicle and she conceived that particular cycle.
Okay.
Yes,
Okay.
I'm giving sometimes 7.5 milligram.
Okay. Okay. Thanks. I really wanted this information.
Yeah.
Yeah.
Okay, I'll just continue.
Yeah.
Now, a little bit about IVF, what we do. Now, when we want to get only remember a couple of protocols. There are many protocols. The long protocol is not popular now. That means it's a long duration. What the patient comes the previous month on day 21 of the cycle here, as you see there. And you'll realize that day 21, you start down regulation. And when she gets the menstruation, we start the second, that is the injections. We give gonadotropin. That means this patient gets down regulation from the previous month. and this month after menstruation for about 10 days. It's too long a protocol and it's expensive and it suppresses the ovaries in some of them. Then we need to give a higher dose. But I think for the audience today, just remember this one protocol called as antagonist protocol. The patient comes on the second day of menstruation. We start the injections of gonadotropin. The dose depends on different patient age, number of antral follicle. I'm not going to talk about that today. It's another chapter by itself. However, after 4 days, you look at that, you start antagonist. Now, this is an important statement because when to start antagonist? Antagonist means you're antagonizing LH. If you don't start when the follicle is about 12 to 14 millimeters, estrogen is more than 400 picogram, it will surge. That means you start antagonist on the 5th day. It's not a fixed protocol, it's a flexible protocol. So remember 4 days of injections and the 5th day, if you find 400 picogram of estrogen and 12 to 14 millimeter follicle, then you start antagonist of 0.25 milligram per day. Let us say on day 5, estrogen is 200, follicles are 11, don't start. Just wait for one more day and then you get good results. If you start early, it will suppress. If you start late, it will surge. I think this is a simple statement to get good oocytes in a IVF cycle, antagonist cycle, starting with estrogen of 400 picogram and LH, follicles of 12 to 14 millimeters. Which gonadotropin? It doesn't matter. Meta-analysis has said that all these are equally good and you can do whatever you want to do. So urinary HMG versus recombinant FSH for control stimulation, the systematic review, 7 randomized trials of 2,000 women, HMG was associated with a pooled 4% increase in live birth rate compared with recombinant FSH in a long agonist stimulation. That means it is good. And of course, Cochrane studies 42 trials over 9,000 couple. They studied that HMG is slightly better in live birth rate compared to recombinant. However, clinical choice of gonadotropin should depend on the availability, convenience, cost, and previous patient response. There is no difference between urinary and recombinant. But as I told you, there are two friends, FSH and LH. If LH should always be a low profile friend, look at that in PCO, a very high LH can suppress the granulosa cell proliferation. It can cause follicular atresia, premature luteinization, and oocyte development can be compromised. A very low LH can also have a poor response. So a poor, very high AMH, you find they have high LH. There is no there is no recommendation to do LH in the literature, but I, for one, would think Asian women have a high LH. I would do second day LH if the AMH is very high, more than 8 and all that. But remember, if the LH is high, you bring it down by giving 1 month, 3 weeks of OC pills, that will come down. So keep that other friend in reserve and not allow the other friend to become dominant. Now, sometimes you find if you do a day 2 FSH, it will be raised. I don't do that anymore. We do AMH. Initially, FSH should be 10. Let us say 10 to 15. We think she has a poor reserve. It's not so. This is called as intercycle FSH rise. The importance of understanding is because the FSH goes up in the corpus luteal phase itself and then it will be raised. If it is raised, it will stimulate the basal follicles. Instead of having all these quiet follicles, there'll be one erratic, 114, 112, and so on. So an erratic follicular development may be seen. If you find on the second day erratic follicles, probably you skip that cycle, or you can give in that particular cycle suppression in the estrogen and progesterone in the luteal phase, thereby bringing the FSH down. I repeat what I said. On the second day, if the follicles are erratic like this, if you start IVF, you will fail, because a certain follicles are already big. So in that cycle, maybe abandon that cycle, start estrogen and progesterone in the luteal phase, and then she'll be okay next cycle. But never forget obesity. Central obesity can cause all these problems, and the visceral fat is the worst fat, and that will cause androgenization and poor ovulation induction. So before you do any induction of ovulation, reduce the body mass index, especially the visceral fat. Now, just want to spend the last 1 or 2 minutes because I have to finish in the 5 minutes. Now, when somebody is under stress, everybody says, how does stress cause problem? The stress is, remember, that pregnenolone is the mother hormone. You know, the high stress and poor sleeping habits causes increased cortisol. And when these issues become a chronic, the pregnenolone it steals the pregnenolone. That means what happens is pregnenolone is a byproduct of cholesterol metabolism that is necessary to produce cortisol and DHA. So if somebody is under stress, what happens? High stress causes a shift towards cortisol production. Look at that, the left side, all it gets pulled. The adrenals will produce cortisol. Stress pulls everything in that direction. This shift essentially steals the necessary pregnenolone from the DHA production. And of course, we have less of DHA, less of other hormones. So when somebody is under stress, the pregnenolone gets stolen towards the opposite side, and the woman doesn't have pregnenolone. So she doesn't have DHA, she doesn't have oocyte. So all these stress can cause pregnenolone steal syndrome. Hence, the culprit behind hormonal roller coaster that affects so many women, even premenstrual syndrome, perimenopause, are all because of stress. So I tell them do some yoga, less of stress and things like that. And who doesn't have stress? Everybody has stress. But remember, chronic stress can lead to pregnenolone steal, a mechanism in which stress robs the sex hormones to meet the high demand for stress hormones as well. And the last part is the Doppler. If you find the Doppler is switched on for a follicle, if there's a good 50% vascularity as shown there is a very good mature, you can give HCG at that time. But I for one would think a stimulated cycle has about 18 to 20 millimeter. Non-stimulated with gonadotropin may be a little less. But however, remember, if you look at the resistance index, it will be around 0.5 at the mid-follicular phase. You'll just remember 0.5 to 0.4. It just drops down by 1 day sometime. And that will cause ovulation in a couple of days' time. So the resistance index falls down 2 days prior to ovulation. You may not do anything about it. You just watch she'll ovulate on her own. So I think adding of Doppler and understanding resistance index is very important. And one more thing is, if you find the follicle is full of blood, that's not a good also. The vascularity can cause hemorrhage into the corpus luteum. You go on stimulating with unnecessary medication. There can be good blood supply, but it will bleed and they'll have a corpus luteal hemorrhagic cyst. So there should be good blood supply in the follicle and the endometrium. And I also would like to check pre-systolic velocity. It's simple. Too much of blood means, again, one more 10. More than 10 is a good PSV. Around 12 is good, 10 to 12. If it is very less, that means blood supply is very less. You have to change the stimulation to a little bit of gonadotropin next time. If you don't find good blood supply, you have to change the stimulation to gonadotropin addition to clomiphene and letrozole. However, remember, all these will be summarized now by saying ovulation induction varies according to different people. Choose the right medication and choose the right dose. Have a good understanding of the physiology. Avoid complications of multiple pregnancy and OHSS. Ranjana and team, thank you so much, Ranjana Khanna, for having invited me. Pleasure was mine with all of you there on the screen and with Hrishikesh by being the chief guest. Thank you so much once again. And
It was our pleasure, Dr. Pratap. Definitely, it was our pleasure.
thank you, Amita, Chitra, and all of Anuradha, ma'am, especially for you for being here, always supporting us.
Dr. Manju Verma is not joined?
मैम का नहीं ज्वाइन हो पा रहा है मैम.
Okay.
अनुराधा मैम, please
ma'am,
unmute yourself.
Dr. Anuradha ji, would you like to give your comments? Huh. Now you are unmuted. No, again you're muted.
Yeah, okay, ma'am.
I'm really always mesmerized after
Really?
listening your talk. And always there are some very positive inputs. Like this time I have learned about the pregnenolone steal syndrome.
Even I have learned it for the first time. I've learned this.
And though I know it, that
I
the
didn't know.
stress causes all these things, but
Huh.
the syndrome name is not familiar to me. I really liked it. And also your verse of 10. I was not much aware of peak systolic wave. That is more than 10. And everything, whenever I remember what to remember, I will remember your 10. That's
Our residents always answer like this. They don't know they'll say
Yeah.
less than 10%. Then they'll say, everybody say Dr. Pratap's number.
Yeah, it's very remarkable. And also you have given many tips to all, and I really like that in routine protocol of us raised LH, which also I go giving. If it is more than LH, more androgenic, it's always superior to give her OCP pill. Not trying much more things and giving for a high dose of gonadotropins. So why I believe it? Because there is two cell theory, and two cell theory also tell us about the androgen converting to estrogen. So if we will give our OCP pill, we are going to make this two cell theory in a correct way, and that will prevent this PCO. And by 2-3 months, she will learn the lifestyle also. And if you want to supplement, like making her B12, like you are giving this manoxidil. Actually, manoxidil is there from the gut, and the gut is to be corrected. So we can correct the gut biosis, we can correct the hormonal milieu, we can lower down the androgens. So all in environment will be corrected in 2-3 months. And now if you go for induction, as beautifully Dr. Pratap has mentioned, all the protocols, they will be there. So it's really fruitful. Similarly for POI, if it is there, then you have to make this. I still believe in giving this. What is that is a
DHA.
DHA. I
Yes.
still believe in that
Yes, all of
because
us.
my what is your comment, Dr. Pratap, regarding
We
this?
are giving, ma'am. When somebody
Yeah.
has, I just mentioned that how the pregnant goes down, even in a POI, then the DHA is less anyway. Though the literature is not clear, there is no harm in giving for 3 months, 6 months, and do an IVF on them.
And what about low AMH? Would you give DHEA?
Yes, I am giving DHA for all my patients.
For how many
And
months, Dr.
3 months,
Pratap?
minimum 3 months, up to 6 months.
3 months.
There's no point giving 1 month because
Yeah, 1 month is useless.
oocyte takes about 3 months for development. So I think the sperms and oocyte are similar. They take 3 months to improve.
Mm.
So,
and
what is the maximum dose that you use for patients who have low ovarian reserve?
For an IVF cycle, I don't go beyond 450 IU per day.
Okay. And do you think that if we combine with an oral ovulogen, it gives better result, or you go only
Uh,
with
yeah, I
gonadotropins?
give only gonadotropin because sometimes this endometrium goes off track with clomiphene. So I think either stick to. See, mine is a very simple method. Somebody is normal with 10 oocytes. I'll start with 225. Let us remember 300, okay? 300
Yeah.
IU, but I usually use less. When somebody has PCO kind, I just do 150. When
Okay.
somebody has 450, so I have only three values: 300, 150, or 450. That becomes easy for my juniors to understand also. But individually, I'll change. Somebody has a PCO, I will may give 225 sometimes. So I think depending on the number of egg, but remember three numbers: 150, 300, and 450.
So if there's a patient with low ovarian reserve, and if even on with a dose like 450, we are seeing only 2 eggs growing, and if the patient says that otherwise also I had 1 egg when I was given oral ovulogen, so how do you explain in that case?
I give them growth hormone. I give one
You
unit
add,
of growth
okay,
hormone for 4 days because that
okay,
comes as 4 IU vial. I give
yeah,
1 IU per day for 4 days at the beginning itself. So you will
okay,
find at least couple of eggs will be better than by not giving.
okay.
Any questions are there in the box?
Dr. Lalita Shukla has posted one question.
Hmm.
This treatment of thin endometrium during induction of ovulation. I think she's asking about oral ovulation.
Yes.
Thin.
If you find thin means that something less than 7 millimeters, you stop clomiphene and you don't give any more. There's no point in giving estrogen in those kind of patients. You stop it and change to letrozole next time. That cycle is gone. Next time you give letrozole and most of them respond. And a little bit of gonadotropin, as I mentioned, sequential therapy of day 7, 8, 9, they become good. If they don't respond for all the time, that means you have to do hysteroscopy, take biopsy for tuberculosis, and of course, check the hysteroscopy. Otherwise, most of them are fine.
But if you have
Ma'am,
given 2.5 milligrams for day 2 to day 6, and then if it's not growing appropriately, would you want to give an extended regime or would you want to give gonadotropins?
No, if the
Simply.
endometrium is not growing well, I would give gonadotropin along with that next time. That cycle is gone. But if you don't find follicle at all, then you give extended regime.
Extended
Yeah,
regime.
but if there's a follicle growing, then the lining is thin, that time you cannot give. Next time you can give gonadotropin.
Okay.
Extended regime is only when there's no follicular genesis.
So
One
do
thing is there
do
that
you
from day 12,
do-
just Dr. Parul, just wait for me. It's from day 12, if you
Yes,
see
ma'am.
it is given CC protocol, then suddenly on day 12, you see the endometrium is very good and having good vascularity also because the blockage has gone. So this is also important. And not only this, in TVS, we have to see not only one part, the whole endometrium, the thin line, the triple line, the flow, that is Appel-Baum criteria. That will be helpful
Yes,
in
ma'am.
diagnosing
Yes,
also
ma'am.
whether she is having genital tuberculosis or not,
Thank
or
you so
any
much, ma'am. I think I have
endometritis.
to log out if you
Ah,
permit me to
good.
log out because I have 2 minutes to log in for
Thank you.
Tik
Thank
Tambe
you
will
so
be
much.
Thank you
giving
so
Thank
much.
you
Thank you.
so much,
Thank you
Dr.
so much.
Pratap, for coming.
Thank you
Thank
so
you
much.
so
And
much.
pleasure is
Thank you,
mine
take
and
care.
Dr. Deepika Chabra from the company side, Jagsonpal, and nice meeting all of you. And
It's our pleasure.
See you in, are you coming to Delhi, AOGD?
no, I'm not coming.
Then we'll be meeting in Mumbai.
Somewhere. Mumbai, yes, for sure. Thank you so much.
Thank
I'll
you, sir.
log out. Over to you,
Okay.
ma'am.
Okay, sir.
Okay, sir.
Anuradha,
Thank you, sir.
ma'am.
Thank
Thank
you,
you
sir.
so
Ranjana,
much,
Thank you, sir.
Dr.
Amita,
Pratap.
Thank you, sir.
Chitra,
Thank you, sir.
Parul. Okay, bye-bye.
Bye.
Thank you, Dr. Ranjana, Dr. Amita, and whole
Any,
team.
Thank you,
any
ma'am. Thank you,
other
ma'am.
questions? Then we can ask Dr. Anuradha Khanna. She's still here.
Yeah, I will like.
Parul?
I love questions. Yeah.
Amita, any questions?
नहीं मैम अभी
Thanks,
नहीं है
ma'am.
नहीं अभी नहीं है
Okay.
Parul, you were
Yes, ma'am.
asking something.
हाँ
हाँ.
I was just asking his experience regarding role of PRP in thin endometrium.
Okay. So what you are getting, Parul?
हाँ
Sorry, ma'am.
What is
What
your
तुम अपना
is
एक्सपीरियंस
your
बताओ
your inputs regarding this?
So basically, if there is a patient with thin endometrium, there are a number of protocols in which you can prepare an endometrium. So I'm talking about an IVF cycle now. If it is a normal ovulation induction cycle where you are planning only timed intercourse or an IUI, then in that case, you obviously are going ahead with letrozole. And if you do not find, it is basically if the follicle is not growing enough, then at times the endometrium will remain thin. So basically, if you monitor the follicle for a day or more, as Dr. Pratap said, sometimes the follicle has reached a diameter of 18 millimeter. But if the blood flows, that is the perifollicular flow, and the peak systolic velocity is not up to the mark, you can even wait for 22 to 24 millimeter maximum. And at times, the endometrium also catches up. And in that case, you do not need to do anything. In some cases, when we add on gonadotropin, then obviously because you cannot cancel an IUI cycle if the follicle is growing well. So you add on few things. You can at times add estrogen when the follicle has reached a size of 14 millimeter. Then also the endometrium grows beautifully. Now, when if it's an IVF cycle, obviously first thing you will do is to freeze embryos. You will find out the cause why it's not happening. Then you can do a hysteroscopy to
This
begin
is
with. That
very
is the
important.
yeah.
The word you said, find out the cause. That
Yeah.
is the most important thing. Yeah.
So we freeze the embryos first, and then we do a hysteroscopy to find out the cause. If there is a adhesions or if there is some polyp or anything, if the uterine anatomy is not up to the mark, and if everything is ruled out, then you can start with a HRT protocol. That is wherein we give estrogen valerate or hemihydrate tablets. You can start with 2 milligram 3 times a day, maximum of up to 12 milligram, because you can give it up till 18 milligram also,
Yes.
but over 12 milligram, even if you keep on adding estrogen, there is no added advantage. We can change the route of administration, like you can use vaginal estrogen or you can use it in the form of gel for local application. There are a lot of adjuvants like aspirin, sildenafil, wherein the guidelines says that there is no added advantage in adding any adjuvant. So then, apart from that, you can do GCSF injections are there. So basically, this you can use like a subcutaneous route or intrauterine. You can instill like we do an IUI sample insemination.
But
So
they are very
basically, there
costly.
no GCSF injection is not costly. It
How
costs,
much
I
is it?
think, 1,000 rupees, something like that.
Okay.
So basically, there is no fixed protocol how you can use a GCSF. You can start from day 9 of the HRT protocol. Then after, it takes 48 hours to show any result. You repeat an ultrasound. If there is no adequate response, you can add it one more time, maximum up to 3 times. Same goes for PRP. Basically, it is how you prepare PRP. Then, so many studies do not mention how that you should activate the platelets before injecting them in the intrauterine cavity. Now we have done
It has to
studies.
be activated.
It has to be activated. So there are studies wherein you can either inject PRP like an IUI sample, or you can do it in the previous cycle with hysteroscopy, along with hysteroscopy using a needle where you are injecting it below the endometrium, subendometrial injection of
Subendometrial.
PRP.
Yeah.
Yeah. So the advantage being because preparation of PRP takes requires less amount of blood sample. Around 20 ml of blood sample is required, out of which you can generate 3 to 4 ml of PRP, and you can inject in all the four walls of the uterus. And again, the result will take 48 hours to come. And then if you're doing an intrauterine insemination, you can repeat it once or twice more. Same goes for stem cells, but obviously because stem cell, to generate stem cells, it is a cumbersome procedure. We do not know long-term effects of PRP also in stem cell side effect per se. And there are few people who say that PRP has no role at all in thin endometrium, at least. So it is mainly stem cells basically which may show some effect. So the baseline thing is, if you look at the anatomy of the endometrium, there is a basal endometrium and there is stratum compactum and spongiosum. So the embryo implants in functional layer, not in the basal layer. So if usually when we say thin endometrium, it is the functional layer which has become thin. But if the basal layer is damaged, no matter whatever you will do, the endometrium will not grow back. So even for stem cells to function at least, or PRP, 20% of the basal endometrium should be intact. Then only it will grow. If that is completely destroyed, sometimes when aggressive DNC is done or after a cesarean section or a myomectomy, then at times the endometrium doesn't grow back. In that case, you have to counsel for surrogacy or adoption.
One more thing, Parul.
Yeah.
In such cases, you can have hysteroscopic uteroplasty, giving longitudinal incisions, because they will make more regeneration of endometrium. And actually, if you see the menstrual blood, which we are having, is having stem cells, and they activate on their own. And I have seen in my practice, the old age practice 40 years before, that I used to inject hyaluronic acid hyalidase along with Dexona, along with normal saline, along with gentamicin. This is just like a hydrotubation. And many of the patients, they get very, very better after that, especially those who had endometritis due to any reason, because of the procedure, because of the tuberculosis, because of doxycycline, whatever. So they are benefit. Our own concept is make the endometrium functional, vascular endometrium there for a better implantation. So we can use many methodology beautifully mentioned by you regarding all the aspects, but we living with the 80% population which is not rich. So this therapy of hydrotubation, which I'm mentioning you, don't take much of the amount, only that says 3 to 5 ml, just to make this preparation. And this is very cheap. Still, I'm practicing that. And that is very, and you use IUI cannula only. Just use IUI cannula, only 1 ml of Dexona, 1 ml of gentamicin, 2 ml of normal saline, and dissolve highly. This is my personal, I have given the thesis also. And that even your sounding, you see, you get the sounding done prior to the cycle. That makes a more vascularity, inflammation, and that also helps in implantation. So your inputs are very good. I really appreciate, Parul.
Thank you so much, ma'am.
Parul, there is one more question. Either ma'am or you can answer. How and when the growth hormone is administered at cost?
The growth hormone is started from day 2 of the cycle. Though at times it is given in the dose of 4 international units subcutaneously per day. So The costing is around, I think the MRP is around 4,000 or 3 to 4,000 per injection.
Per injection.
At times, there might not be any effect, like added advantage of using growth hormone. But as sir said, sometimes we have to do everything, just before we give up that the follicle is not growing. At times, we have used it later in the part of the cycle when we have started with the gonadotropin, and if the response is not adequate, we step up the dose to the maximum 450, but some doctors also go up to 600. So when there is no response after say 4-5 days, then also they add growth hormone. But the best result should be added from day 2 itself till the day of the trigger.
Ma'am, this is a question from Dr. Mahima Lalwani. At what time of cycle is Dexona and Syngenta inserted? And what are the
This
indications
is
after
day
menstrual cycle?
7, day 8, day 9, any day. Mid-follicular phase. Because this is not going to do any harm. Or if suppose she has come on day 20, then we are not sure whether she had already embryo in the tube or not. So if you will push anything, it is likely to have ectopic pregnancy. So this is, she is asked not to have any marital relation, like in HSG, we do. And even after HSG, I used to, whenever suspected tuberculosis, anything, I asked my sonologist, the radiologist, that you inject also Genta, Dexona, and normal saline, because that gives a way and it is a therapeutic also. But unless if you are having any PID or active genital tuberculosis, no interference. Any either adulteration or it is a HSD, nothing should be done. You treat the pathologist and then after you plan for it.
Ma'am, have you used this treatment in patients who were not menstruating because of endometrial issues and then their menstruation resumed?
No, I have to go then for hysteroscopy, not hydrotivation, because if she is non-amenorrhea, so you have to work up her primary or secondary amenorrhea, whatever you are thinking. Complete workup in which there is no role of hydrotivation. But if she had a history that she had a proper menstruation and now it is becoming scanty, and you got your hysterosalpingogram done, HSG, and you are getting a finding which is suggestive of tuberculosis or endometritis, then you first get it treated and then later on. And always you get it done along with the sonology Doppler flow, because sonology Doppler flow will let you know about the ovarian follicles development, the vascularity, and about the implantation factors. That is you have to follow the Appelbaum criteria. Whether what is the follicular stage, what is the endometrium, what is the zonal flow. So all these things has to be taken care to understand that patient, because every patient has got a different recipe. We cannot say this is this for this patient to all the patient. No, we have to work up the patient with our knowledge, with our intelligence. This is not AI. This is your own brain. AI will not work here. That will make you confused. So we have to work for each and patient detail history. वो आपको एक बार में बताते भी नहीं है कि क्या क्या पास्ट में हुआ. History of abortion, history of taking oral MTP. Even you all people are getting lot of cases who have been aborted by oral mifepristone and misoprostol. And you see they are having infertility. I think why they are having infertility? Because of the maybe mifepristone has blocked for a longer time. You never know. So again, we have to work up the case in detail as starting from A to Z. Then only we will come to know what is the things. And they are so, and Dr. Pratap Kumar has mentioned so nicely about this pregnenolone steal syndrome, stress factor. And you see, meditation works a lot in such cases. I really appreciate the diet and the meditation, because you see hypothalamus pituitary axis. From here, everything is concerned. And by taking this meditation, the deep breathing, and by removing the stress, it is very easy to say remove the stress, but it's very difficult to remove the stress. Even I think on myself, it's not easy thing. But still, if you exercise, take proper nutrition, have a walk in morning, evening, So lot of things I learned. So similar is with the patients also.
There are some more questions. Should we take it or
Yeah.
should we end? And one is, what is ovarian remnant syndrome?
What is
Ovarian remnant syndrome.
resistant होगा, remnant नहीं होगा. Ovarian resistant syndrome. Remnant नहीं होगा.
Remnant लिखा है मैम, resistant ही पूछा था.
रेमिनेंट तो ये हुआ कि आपकी ओवरी रेमिनेंट रह गई. अगर आपने सर्जरी करी और उसमें थोड़ा सा पार्ट छूट गया तो वो रेमिनेंट हो गई. ये तो रेमिनेंट सिंड्रोम है. तो उसमें पेशेंट में भी स्टिल हैविंग सम फॉलिकल डेवलपमेंट. बट इफ इट इज रेजिस्टेंट सिंड्रोम दैट मींस कि हम उसको क्लोमिफेन साइट्रेट या लेट्रोजोल दे रहे हैं, इट इज नॉट रिस्पॉन्डिंग. In such cases, the gonadotropin will be of better help and find out the receptor defects. In resistance syndrome, there's a receptor defects.
And someone is asking about fertility treatment in Sheehan syndrome.
Sheehan syndrome, gonadotropins. Because FSH, LH all are lacking, so you give gonadotropins. And rule out the other factors also. Always think of the endometrium, uterine size, and other things in endocrine value.
So, thank you, ma'am. Thank you,
Thank
Parul.
you.
And after this wonderful scientific evening, the time has come for formal vote of thanks. My heartfelt thanks to our chief guest, Dr. Hrishikesh Pai sir, for his blessing and presence. Special thanks to Anuradha Khanna ma'am for her valuable inputs and making this
Thank
talk so more special. Words are not enough to thank Dr. Pratap Kumar sir's talk. His talk is just like a lesson in the classroom, and he is like a teacher in whose class we want to go and sit in the front row. Thank you, sir, for this wonderful talk. There are so many take-home message things, and my special thanks to Ranjana Khanna ma'am for choosing this topic and speaker, and always motivating and guiding us to do better in our clinical life and all the things. And my thanks to our co-convener, Dr. Parul. Dr. Parul has आज तो उसने और भी convene के अलावा और भी roles अदा किए.
बहुत अच्छा.
Yeah, thank you, Parul.
Thank you.
And I want to thank Jagsonpal and especially Dr. Deepika for always supporting our webinar. Now we have reached at around 38th webinar, and thank you so much for helping us. Thank you, Dr. Deepika. Over to you,
We want
Deepika.
to do 40 before we
Yeah.
hand over the ISOPARB charge.
So over to Dr. Deepika.
Yeah, thank you so very much. And it was such a good talk by such a eminent speaker that you had arranged, ma'am, really. So now I just present to you a couple of our products, like for to restore the ovulation and reproductive women. We have Cystilia M, myoinositol, and D-chiroinositol in the ideal ratio of 40:1. Doxipal DRL, you are all aware of and have been prescribing. Keep giving us support. This is doxycycline 100 mg with lactic acid bacillus. And now our newly launched product. This is our brand FE Protein. FE Protein, which is iron-rich brand, which gives benefits of the combination of lactoferrin with ferrous bisglycinate and all the other nutrients that a pregnant woman needs during her pregnancy. So we're looking forward to your support for FE Protein also. So thank you so very much. And ma'am, with your permission, we can end this meeting.
Yeah.
Thank you so much.
Thank you.